Okay. All right, well, welcome everyone. Thanks for joining us. I mentioned to Golam, I gave a little bit of background about the seminar series, but for those of you that didn't hear me, this is co-organized by Integrative Medicine, a clinical department, and our basic science department, my home department, Department of Pharmacology and Physiology. So this is part of the GW Biomedical Cross-disciplinary series. So the goal is to sort of bring people together, promote networking and collaboration from different disciplines, and with the idea that this could help accelerate the discovery of novel therapeutic strategies. And this year is the inaugural year of the seminar series, and inflammation and chronic disease is the topic. So it's really a pleasure and honor that we have our speaker coming from the UK, virtually, Dr. Golam Khandaker. He's a professor of psychiatry. He's head of immunopsychiatry and experimental medicine program at University Cambridge, and now more recently as an appointment at the University of Bristol in the UK. So Golam's research focuses on identifying and validating novel immunological mechanisms and potential treatment targets for depression and schizophrenia. He also has an interest in looking at the role of the immune system and neuropsychiatric disease associated with cardiometabolic disease. And he primarily uses epidemiological cohort studies, genetic analysis, and early phase clinical trial approaches. So the big goal of and motivation for Golam's research really focuses on translating immunotherapies closer to the clinic. And he's done some of this work. He's been a pioneer in identifying certain inflammatory cytokine signaling pathways, such as the IL-6 pathway, and it's linked to psychiatric disease. Golam has published extensively. He's received a number of major funding awards, and he was selected in 2017 as a rising star in psychiatry by the UK's National Institute for Health Research. So without further ado, I'm going to give the floor to Dr. Khandaker, and he's going to be talking to us about the role of the immune system in depression, exciting therapeutic opportunity, or blind alley. Thank you again, Golam. And let's see, for questions, we'll have some time. I hope you're able to entertain some questions. So we could put them in a chat box, or feel free to turn your video on and interact with our guest speaker. So thank you again.
Thank you, Paul, for a very kind introduction. And first of all, for inviting me to be part of this seminar. As I was telling earlier, that I would have much preferred, of course, to do this in person, and the advantage being that visiting the lovely city of Washington, D.C. and meet you all in person. But I suppose for this year, it will have to do thanks to Zoom that we can still meet. Just a signal from Paul. Can you see my screen, the full screen now? And can you hear me all right?
Yep, perfect.
Okay, thank you very much. So I will talk about role of immune system in depression, and I'll show you some of the work that we've been focusing on in the last few years, looking at whether inflammation could be a causal risk factor for depression and whether this could lead to new ways of treating this condition. So briefly, I will touch on, firstly, why we think that as psychiatrists and neuroscientists, we should be considering a role of inflammation and immunity. I will touch on some of the key evidence that links immune system with depression and risk of major psychiatric disorders more broadly. We will spend a bit more time in the talk thinking about potential causality of association, whether inflammation is likely to be a causal risk factor. And finally, finishing with prospect for immunotherapies, so translational impact of this work for treating people with depression. As you know, that depression is one of the leading health challenges of our time. I mean, it features highly on global ranking for health-related disability in developing countries and also in developed countries equally. There are a number of reasons why depression has such a major impact on individuals and society. It's a common condition. Lifetime prevalence is about 10 to 20%. It starts early. So 25% of people with a lifetime diagnosis of depression will first experience the illness before they reach age 20. It's a recurrent condition. So chance of having a second episode is 50%. And the probability of getting a fourth depressive episode in someone who's had 3 episodes previously is 90%. Although antidepressants and psychotherapies help a lot of individuals with depression, currently about a third of patients with depression do not respond to antidepressant medications or psychotherapy. So they're classed as treatment-resistant depression. So it's poorly treated. Depression is also comorbid with a number of physical conditions such as cardiovascular disease, musculoskeletal disorders, and so on. So as a whole, you can see why depression has such a major impact on well-being at an individual level and family and societal level. Depression is a syndrome. It consists of a number of symptoms being present for a certain period of time to meet the definition for depressive episode according to ICD-10 criteria that we use in Europe, or DSM-5 that is used in the United States. But fundamentally, the pathophysiologic explanation and approaches to drug treatment for depression is predicated on monoamine neurotransmitters. However, there is a great deal of heterogeneity in clinical presentation, treatment response, and prognosis that suggest that other mechanisms are involved. So I've borrowed a slide from a colleague, Brenda Penix, in Amsterdam, that I believe illustrates the issue of heterogeneity in depression beautifully. So here I've simply listed symptoms of depression that we as clinicians consider to make a diagnosis of depressive episode according to ICD-10 criteria. So as you can see, there are first 3 symptoms of depression. These are known as core symptoms, so low mood, fatigue, and anhedonia, or lack of pleasure. And then there are a list of about 13 secondary symptoms. So to meet criteria for depression according to ICD-10, and it's very similar for DSM, an individual has to have at least 2 out of these 3 core symptoms and 2 out of those secondary symptoms. So 2 plus 2 present for about 2 weeks, and that meets criteria for depression. So a quick mental exercise. If we take 2 from 3 and 2 from 13 each time, how many unique combinations are possible, all meeting criteria for depression? I'm sure if it was face-to-face, somebody would have shouted out the answer by now, probably a clever postdoc. It's 234 unique combinations possible. So just illustrating the point about heterogeneity. So it is very likely that a heterogeneous condition like depression, there are multiple mechanisms could be implicated in pathogenesis of this illness. And our work, along with work from a number of other groups, indicate that immune system, inflammation particularly, could play a role in depression. So before going into evidence showing, supporting a role for immune system in depression, first, an overview of what we mean by inflammation in the context of psychiatric disorders. So some of you will know, the physicians particularly, that our immune system is broadly classed into 2 groups. So innate immunity, that's our first line of defense against microbial infection. This is rapid and non-specific. And the second line is adaptive immunity, which is slow but highly specific, and it operates by lymphocytes producing antibodies. I mean, that's the purpose of vaccines, for example. So COVID-19 jabs that many of us are having these days, that's the remit of adaptive immunity, targeting a specific antigen by producing antibody against it. My work, and for this lecture particularly, we are concerned about inflammation. So that's the product of innate immunity. And innate immunity is mediated by white blood cells, such as macrophages and lymphocytes, producing small proteins. These are called cytokines or acute phase proteins. You can think of them as similar to neurotransmitters for the immune system. So these molecules help white blood cells to talk to each other and to mount an immune response. And this is, of course, essential for survival, because we need a healthy immune system to fight off infection and various other internal and external threats. But a chronic low-grade activation of innate immune response can be harmful. Now, in addition to infection, there are a number of other factors that can activate our immune response, some of which are well-established risk factors for psychiatric disorders. So the typical proteins that I have looked at and are archetypal inflammatory markers are acute phase proteins like C-reactive proteins, or cytokines such as interleukin-6, interleukin-1 beta, or TNF-alpha. Now, innate immune response can be activated by psychological stress, bullying, victimization, sedentary lifestyle, and these are all well-established risk factors for psychiatric disorders. When I went to medical school about 30 years ago, we were taught that our brain is an immune-privileged site shielded behind the blood-brain barrier, and anything that is immunologically harmful circulating in our body, whether that's immune proteins or antibodies, that cannot enter the brain. Over the last 2 and 3 decades of work, we know that this is far from the truth. In fact, the blood-brain barrier is not so much of a barrier, it's an interface. I think Andy Miller made that point very eloquently last week. There are a number of pathways through which systemic inflammation can communicate with the brain and influence mood, cognition, and behavior. So this is an excellent review by Robert Dunza that illustrates some of the pathways. Since then, a number of other pathways have been identified, including lymphatics. For sake of time, I wouldn't go into the biology of immune-brain interaction too much, although this is a highly exciting area, but these two reviews summarize nicely some of the consequences of immune signal reaching the brain. So these include decreased production of serotonin, increased presynaptic reuptake of serotonin, increased release of glutamate, leading to excitotoxicity, increased concentration of reactive oxygen and nitrogen species, leading to oxidative stress, and decreased neurogenesis. So you can see how these biochemical changes could be relevant for symptoms of low mood, cognitive difficulties, and so on, that we see day in and day out in psychiatric clinics in patients with depression or psychotic disorders. So now moving on to some of the clinical evidence pointing to a link between immune system and depression. First of all, the first line of evidence comes from observation in patients with hepatitis C virus who are treated with interferon A. Now, interferon A is a potent inducer of innate immune response. It's necessary to clear off the virus from our system, but clinicians have known for a long time that one side effect for this treatment is depression. So about 40% of patients develop major depressive episode. So now this is a smoking gun evidence that activating our innate immune response leads to depressive symptoms. Subsequent experiments done in healthy volunteers. So this is an example from Neil Harrison's lab in Cardiff University that shows that we don't need a massive degree of activation of innate immune response. Even a small activation of innate immune response with typhoid vaccine in healthy volunteers leads to, as you would expect, increase in concentration of inflammatory markers in blood as early as 2 to 3 hours. But it also mirrors with increase in depressive symptoms, anxiety symptoms, and reduced performance in cognitive tasks as early as 3 to 4 hours post-vaccination. So this is another example that even mild degree of activation of innate immune response can have a measurable impact on mood and cognition. Second line of evidence comes from neuroimaging PET studies. And they show that compared to healthy controls, patients with depression have increased activation of microglia. So microglia are a type of cells. These are, with regards to lineage, similar to macrophages and monocytes in the periphery. And activation of microglia is thought to represent neuroinflammation. And a number of studies now confirm that there is evidence of increased microglia activation in patients with depression compared to healthy control. The third line of studies come from studies that have looked at concentration of inflammatory proteins in patients with depression compared to control. Hundreds of these studies have been done, and these have been subject to a number of meta-analyses covering tens of thousands of patients. I'm showing an example here which shows that the effect size for elevated IL-6 levels in depressed patients compared to controls is 0.5. I'm not showing the data for other cytokines, but they show broadly similar picture. So pro-inflammatory cytokines and proteins such as CRP, TNF, IL-6, these are all increased as a group in depressed patients compared to controls. We have recently looked at data from UK Biobank cohort, which is a cohort of about 500,000 people from UK. And there we have looked at association between C-reactive protein concentration and depressive and anxiety symptoms. As you can see, there is a linear dose-response association between higher CRP and higher depressive symptoms. So the red line represents depressive symptoms and the blue anxiety. And the strength of association is much stronger for depressive symptoms than anxiety symptoms. We also see similar picture for patients with psychotic disorders. Here, during an acute episode of psychosis, concentrations of pro-inflammatory markers such as IL-6, TNF, interferon, these are increased, but anti-inflammatory markers such as interleukin-10, that's decreased. But the picture normalizes itself after successful treatment when symptoms disappear. So pro-inflammatory cytokines come down and anti-inflammatory markers come up. So simply looking at a peripheral blood signature of immune proteins in acute depression or psychosis, it would appear as if our immune system and body is reacting in a way as if it's fighting off an infection. But the key point here is that, of course, the magnitude of cytokine response or immune response is not as extreme as you would expect in the case of an acute infection like the flu, but the direction of travel is exactly the same. So pro-inflammatory cytokines going up, anti-inflammatory cytokines going down. Some studies have looked at materials that's anatomically closer to the brain, such as cerebrospinal fluid. They also confirm that concentration of interleukin-6 and other pro-inflammatory markers are higher in patients with depression compared to control. Now, one thing to remember that not everybody with depression show evidence of immunoactivation. So we recently looked at data in published studies where CRP was measured as a measure of inflammation. And we used CRP concentration 3 milligram per liter or above to index inflammation. And using that threshold, we see that about a quarter of depressed patients have high CRP levels. So I think an important point to keep in mind that while inflammation may be relevant for depression, it's certainly not relevant for everybody with depression. Now, I will spend a bit of time thinking about whether the association between inflammatory proteins and depression likely to be causal. The particular two questions that I have been concerned about over the last few years are issues of reverse causality and confounding. So it's entirely plausible that increased inflammatory markers in depressed patients are in fact a consequence of illness rather than be its cause. Because I've already told you that psychological stress can activate our innate immune response. And you don't have to be a psychiatrist to know that depression and psychosis, these are extremely psychologically stressful conditions to have. The other explanation, of course, could be confounding. So it's possible that association between inflammatory markers and depression are explained by a third factor that's related to both exposure and outcome. So I will unpack some of these these two questions in the next few slides. So to address the question of reverse causality, so cause and effect, we have looked at longitudinal population-based studies where inflammation was measured before the outcome of depression. So I used data from a birth cohort in southwest of England called Avon Longitudinal Study of Parents and Children, ULSPAC. We had data on serum interleukin-6 and CRP from about 5,000 children when they were 9 years old. And these children were then assessed for depressive symptoms and psychotic symptoms at age 18. And it's a deeply phenotyped cohort, so we also had data on a number of potential confounders that we thought were important, including age, sex, body mass index at the time of biomarker assays, maternal depression score, and childhood psychological and behavioral problem before measurement of inflammatory markers. And we excluded about 500 children who had an infection at the time of blood collection for CRP assay, an IL-6 assay. So here, you are looking at the data. In the left, cases of depression, in the middle, psychotic symptoms, and on the right, psychotic disorder, grouped by, at age 18, grouped by level of IL-6 at age 9. And as you can see, there is a stepwise increase in risk of depression and for psychotic symptoms for increasing levels of IL-6 at age 9. And evidence for these associations remained after controlling for the confounders that I have named earlier in the previous slide. So this is one of the first evidence from human epidemiological studies showing that inflammation is longitudinally associated with subsequent risk of depression and psychosis. So it's possible that inflammation is simply not a consequence of depression. It could well be a cause for the illness. These findings have been replicated in other samples. So this is a study using a birth cohort in Finland, where we have found that higher CRP levels in adolescence is associated with risk of schizophrenia subsequently in adulthood. This is a replication using Swedish population-based data, where we show that higher ESR, so erythrocyte sedimentation rate, so it's a crude marker of systemic inflammation, is longitudinally associated with subsequent risk of schizophrenia. This is an independent replication by a research group in University College London, where they used data from a Dutch cohort showing that higher CRP level at baseline are longitudinally associated with subsequent persistent depressive symptoms. How about the issue of confounding? So confounding could be an explanation. It's difficult to tackle this issue in observational studies. One design that is widely used these days, and some of you may be very familiar with this, is called Mendelian Randomization. It's a way of addressing confounding in observational research by using genetic variants as proxies for the exposure. How does it work? So it's based on Mendel's second law of inheritance, that we inherit our genes or traits, as Mendel called them, independently of each other. So for example, the gene that gives me black hair, I've inherited that independently of the gene that gives me brown eye color. And how does that help to overcome confounding? So the principle of Mendelian randomization is, so if a biomarker, say interleukin-6, is associated with depression, genes that regulate IL-6 levels or activity should also associate with depression. And if that's the case, that suggests that the original biomarker disease outcome association is unlikely to be fully explained by confounding. And this is because while the association between IL-6 and depression may be confounded by your socioeconomic status, lifestyle, diet, and many other factors, the fact that any one of us has inherited a copy of a genetic variant that gives you high IL-6 or low IL-6, that in theory has nothing to do with whether you went to whether your family socioeconomic condition, or whether you take exercise in your leisure time, or you go down the pub. So using this design, cardiovascular epidemiologists have shown that interleukin-6 could be potentially causally associated with risk of coronary heart disease. We have applied this design for depression, where we looked at association between 16 cardiometabolic risk factors with depression. So we used data from a UK Biobank cohort again. So 367,000 people of European ancestry, about 15,000 of those had a probable diagnosis of lifetime depression. We included a number of inflammatory markers, including interleukin-6, CRP, and also metabolic markers, so BMI, waist to hip ratio, blood pressure, cholesterol, and triglycerides. And we performed Mendelian randomization analysis for each of these biomarkers. And here you can see, after correcting for multiple testing, we see evidence for MR association for 3 of these biomarkers: triglycerides, IL-6, and CRP, suggesting that these 3 biomarkers could be causally associated with depression. In other words, their association with depression is unlikely to be fully explained by confounding. We have subsequently expanded this work with other inflammatory markers and other disease outcomes. So here, we've recently completed a study looking at associations of about 20 inflammatory markers, including cytokines, acute phase proteins, and cells, immune cells, in relation to schizophrenia, major depressive disorder, and bipolar disorder. Here you can see that using Mendelian randomization analysis, we pick up signal for a number of inflammatory markers in relation to schizophrenia. But the picture isn't as straightforward. Here you can see that while interleukin-2RA, IL-6, IL-9, CRP, MCP, and BDNF, these are associated with depression, some of the signals are surprising. For example, IL-6 and CRP are both associated with schizophrenia, but while higher IL-6 as activity seem to increase risk of depression, higher CRP decreases risk of depression, schizophrenia. This is puzzling because IL-6 stimulates production of CRP in hepatocytes. So you'd expect IL-6 and CRP to have an effect in the same direction, but we actually don't see that. We see their effect going in the opposite direction. For depression, we don't see much effect at all, and the same goes for bipolar disorder. Interestingly, when we control for effect of these biomarkers for each other in multivariable Mendelian randomization, much like the same way in multivariable logistic regression, we see that the protective effect of CRP is completely explained after adjusting for IL-6, and IL-6 still remains associated with increased risk of schizophrenia, whereas when we adjust for IL-6 and CRP and IL-2 mutually for each other, now IL-6 shows a significant association with depression. We have done more work on this particular question, looking at using genetic variants to trying to tease potential causality of association using large population data, and I'll share some of those in a moment. So one example here, and these has given us some important clues, but also given us important questions to study further. And these are particularly related to specificity of association, both exposure, IL-6 and CRP, and also with regards to outcome, depression and anxiety. So this is a study hot off the press. It's uploaded in preprint. And here we have again carried out Mendelian randomization analyses using IL-6 and CRP with regards to depression and anxiety as outcomes. And what we find here is that while, and this is tricky, so I would ask for a bit of attention. So genetic variants in IL-6 receptor locals, so in IL-6 receptor genes that increase CRP levels, that we see to be associated with increased risk of depression. Whereas CRP genes that increases CRP level, we find that decreases risk of depression. So there is a disconnect here. So the IL-6 gene increasing CRP increases risk of depression, whereas CRP genes increasing CRP decreases risk of depression. How do we explain that? Our current thinking is that, IL-6 receptor genes increasing CRP levels, it can happen two ways, either via IL-6. Those of you who know IL-6 biology will know that that could happen in one of two ways. One is IL-6 classic signaling through membrane-bound receptors, or through IL-6 trans signaling through soluble receptors. Now, we believe that this is probably likely to be due to IL-6 trans signaling, because CRP genes that increases CRP level, we see that's protective or decreases risk for depression. And we know that IL-6 directly stimulates CRP production through classic signaling pathway. So one explanation for this divergent effect for IL-6 and CRP could well be that here, actually, the main culprit is IL-6 trans signaling. This is a hypothesis, of course, that needs experimental designs in humans and animals to test more conclusively. The other, not so much of a divergence, heterogeneity is, of course, regards to association of inflammation with different types of affective symptoms. Now, this is a project we have recently finished. It was a pleasure to do, because I had the opportunity to work with a group that I have long admired their work. So Yuri Melanchi, Femke Lemars, and Professor Brenda Penix from Amsterdam. So many of you would know that they have a well-characterized and well-researched cohort of depressed patients called the Netherlands Study of Depression and Anxiety. So we joined forces with two cohorts, so UK Biobank from our side and NESDA cohort from Dutch side, and ran tests for association between CRP concentration and symptoms of depression and anxiety. And we followed that up with Mendelian randomization analysis, testing potential causality. And to sum up this, it feels like a big work because it took us a lot of time and effort because of the nature of the data sets. The bottom line seems to be that on the whole, the association seems to be stronger for depression rather than for anxiety. And within depression, the association seemed to be stronger for certain types of depressive symptoms, the so-called somatic or neurovegetative symptoms of depression, such as fatigue, anhedonia, appetite disturbance, sleep problem, than so-called psychological symptoms of depression, such as hopelessness, guilt, and so on. And again, with Mendelian randomization, we provide evidence that interleukin-6 could be causally linked with risk of depression, whereas for anxiety, we do not see that. So it looks like that inflammation could be a specific risk factor for depression, and more specifically within depression for somatic and / neurovegetative symptoms of depression. Now, inflammation, those of you who've been following the work coming out of Netherlands would know that it goes hand in hand with metabolic disturbance. So this is an elegant review that summarizes a lot of work by Yuri and Professor Penix's group proposing the idea of a phenotype called immunometabolic depression. So inflammation being more strongly associated with patients with certain types of symptoms, such as atypical depressive symptoms, so latent paralysis, hyperphagia, so eating more and sleeping more. We also see in a recent study where we looked at association between metabolic dysfunction, inflammation, and depressive symptoms, there is clear evidence that, and this was a genetic approach, so we did genetic correlation between BMI, CRP, and depressive symptoms, and Mendelian randomization to test potential causal associations for inflammatory markers and body mass index with depressive symptoms. And we confirm that BMI is potentially causally associated with a number of depressive symptoms, namely anhedonia, fatigue, and increased appetite or weight. And we also show that BMI is correlated with depressive symptom much at the similar magnitude as the correlation for CRP and depressive symptoms. We also see evidence for this in patient samples. So this is a study in the ULSPEC cohort where we had data from 215 young adults with depression, and we compared them with healthy controls. But depressed group, we also compared them with those who had high CRP versus low CRP. And it was very clear, clearly shown in this study, that the depressed patients who have high CRP or evidence of inflammation, these patients have evidence of cardiometabolic dysfunction, namely obesity, so increased BMI, insulin resistance, and dysglycemia. So triglycerides level are high, insulin sensitivity score is low, and their BMI is high. Look, taking a developmental perspective into development of different components of metabolic alteration seems to point that obesity and insulin sensitivity have distinct association with risk of depression and psychosis. So this is a recent study from ULSPEC BART cohort that we have just published. Here, we used longitudinal repeat measure data from birth up to 24 years of age to model trajectories or population subgroups of body mass index and insulin levels. So as you can see, insulin falls into three categories. So one trajectory, the class 3, that's persistently high levels. One is that increasing gradually over time, but majority of people are in the normal range for throughout the follow-up period. For BMI, we see there are 5 trajectories. One is pretty much within normal range throughout. A small subgroup has persistently high BMI throughout. One group starts heavy and then gradually falls within normal range. But there are these two groups that we called puberty onset BMI increase. These two groups have BMI within normative range up to puberty, age 10, 12, and that time their BMI takes off. And this is, we call it post-pubertal major increase, and by age 24, they are the heaviest. And this group also goes up, but not as much. Interesting results emerge when we look at association of these trajectories with risk of depression and psychosis. And here you can see that insulin trajectories are associated with the risk of psychosis, where BMI trajectories are actually associated with risk of depression. So to summarize what I've said so far, reverse causality and residual confounding are unlikely to fully explain previously observed associations of depression with interleukin-6 and other inflammatory markers. So these are based on population-based longitudinal studies and genetic Mendelian randomization studies. So these associations are consistent with potentially, and I stress the word potentially because these are observational epidemiological studies, not experiments, potentially causal, with a potentially causal role for inflammation in depression. We need to do further work to understand divergent genetic effects of IL-6 and CRP with depression. Of course, the observational epidemiological evidence and the clinical evidence from patients is very clear that patients with depression and psychosis have higher levels of both of these proteins, IL-6 and CRP. But when we use genes to index these proteins, we see their effect go in opposite direction. So this is surprising, but perhaps could lead to important discoveries about particular mechanisms that are relevant for pathogenesis. As I was alluding earlier, that a particular role of IL-6 trans signaling, and that this hypothesis needs testing. Metabolic dysfunction is associated with immune activation and depression. Obesity and insulin resistance seem to have a distinct association with depression and psychosis. So obesity with depression and insulin resistance with psychosis. Now, finishing off with the concluding part. So what does all of this mean for our patients? Therapeutic implications. Inflammation, it matters. It's a clinically relevant phenotype because inflammation is associated with poor response to treatment, antidepressants and antipsychotics. A lot of studies have been done showing this effect. I'm showing an example here that activation of innate immune response at baseline associated with poor response to antidepressants. This is another study done in Cambridge. This is a study by friend and colleague Valeria Mondelli showing the same thing in patients with first episode psychosis, that patients who have higher levels of inflammatory markers at presentation at 3 months down the line, they are less likely to respond to antipsychotics compared to patients who do not have immunoactivation. So if that's the case, could anti-inflammatory drugs be helpful to treat depression? A lot of randomized controlled trials have been done where patients have been given an anti-inflammatory drug in addition to an antidepressant or antipsychotic compared to antidepressant or antipsychotic alone to see whether they have an additional advantage in reducing symptoms. So this is a beautiful systematic review and meta-analysis done by Ole Kohler-Forsberg, published in JAMA Psychiatry, showing that on the whole, non-steroidal anti-inflammatory drugs and other types of anti-inflammatory drugs improve depressive symptoms. So the effect size combined is about 0.3. We have also looked at this question, but we have focused on a particular type of drugs, so anti-cytokine drugs. And the reason for focusing on these drugs was specificity of effect, because these drugs target particular cytokines with surgical precision. So unlike non-steroidal anti-inflammatory drugs that can drug, those by definition are broad spectrum, these drugs are highly specific with regards to their mechanism of action. So an anti-IL-6 receptor monoclonal antibody will switch off IL-6 signaling and will leave rest of the immune system alone. So here we can be certain that the effect of these drugs are exclusively being mediated by the immune system. And these drugs are routinely used for treating chronic inflammatory disease in general hospitals, so rheumatoid arthritis, inflammatory bowel disease, psoriasis, and so on. So these are called monoclonal antibodies or anti-cytokine drugs, or more commonly biologics. And dozens of trials have been done for these studies. Some of these trials also looked at depressive symptoms before and after treatment. And I'm showing you data for double-blind, placebo-controlled, randomized trials. And here you can see that anti-cytokine drugs have a noticeable antidepressant effect size being 0.4. So many of you know that the effect size for antidepressant of effect for SSRI is actually very similar, 0.3, 0.4. I'm not claiming here that these drugs are better antidepressants, but it's a proof of concept that these drugs actually improve depressive symptoms. Now there is a caveat here, because these trials were not designed to test antidepressant efficacy, and you could well argue that these patients are feeling better simply because their arthritis is better. So we have looked at this question in a way to see whether there is any correlation between improvement in their arthritis or physical illness and improvement in depression. And we expected if depression getting better was simply an artifact of their physical illness getting better, there would be a perfect correlation between the two. We do not see any evidence for that. Recently, another industry-led meta-analysis replicated our findings. Interestingly, they find exactly the same effect size, 0.4, but they did this analysis whether this effect is mediated by improvement in physical illness in a different way. They had access to individual participant data, and they simply focused their analysis on a subgroup of patients who did not respond to their primary disease outcomes. So if the trial was for arthritis, their arthritis did not improve whatsoever. And this forest plot shows, even in that group, anti-cytokine drugs noticeably improve depressive symptoms. As you can see, quite substantially large effect sizes for a number of anti-cytokine drugs, such as anti-TNF, anti-IL-6, and so on. So in other words, summarize, anti-cytokine drugs improve depressive symptoms independently of improving physical illness. So again, supporting the idea that inflammation could be causally linked to depression, and immune system could well be a useful target for treating depression. So now who could benefit from immunotherapy? If that's the case, I think that's probably the single biggest question for our field now. So which patients would benefit from immunotherapy? One size does not fit all. I've told you already that inflammation is unlikely to be be-all and end-all explanation for every patient with depression. If it is relevant, it's likely to be relevant for a subset of patients with depression. So this is an elegant trial from our previous speaker from last month, Andy Miller, where they gave infliximab, anti-TNF monoclonal antibody, to patients with depression. And you already know from his talk that overall the study didn't find that infliximab helped. But secondary data showed that there was a correlation between improvement in depressive symptoms with baseline CRP levels. So the higher the baseline CRP level, the greater the improvement in depressive symptoms. I'm aware the 95% confidence interval for these point estimates are rather large, but you can see a stepwise improvement in depressive symptoms as baseline CRP increases from 1 to 3 to 5. This has face validity. I mean, why would you give an anti-inflammatory drug to a patient that does not have any evidence of immune activation? Or when you do give that drug, patients who have greater immune activation, they show greater benefit. It seems to fit. And this finding has channeled a whole body of research effort to testing this hypothesis, whether giving anti-inflammatory drugs to depressed patients who have evidence of immune activation could be useful. I think in addition to that, better understanding of characteristics of inflammation-related depression would help us refine patient selection in future clinical trial. So if inflammation is relevant, which patients is it relevant for? So a lot of work's happening in this theme. So I've showed you some evidence that points to association with somatic symptoms, cardiometabolic disturbance. There are also studies pointing to alteration in immune cell counts, antidepressant resistance, but there are a lot of work currently ongoing, including in our lab, trying to understand biochemical and phenotypic characteristic of patients with depression where there is evidence of inflammation, because there may well be a subtype that could be amenable to immunotherapies. So this really paves the way for personalized medicine. So based on the evidence that I have shared with you so far, we are currently conducting a randomized controlled trial of tocilizumab. It's an anti-IL-6 receptor monoclonal antibody which blocks IL-6 signaling completely. It's a licensed treatment for rheumatoid arthritis. And our hypothesis is, does blocking IL-6 signaling improve mood and cognition in patients with depression? We are recruiting 50 patients with depression that will be randomized to either drug or placebo. The trial is 60% complete. We have treated about 30 patients up to now. And it's a very selective trial. Based on what we think we know, we are selecting patients with ICD-10 depression. They have to have evidence of immune activation, so CRP levels 3 or more. They also have to have inflammation-related symptoms. The somatic symptoms score has to be over a certain threshold to meet criteria for depression. This is the design, how we randomize. It's a deeply phenotype study. After infusion, patients come back weekly for a month. And a single dose of tocilizumab is equivalent to a month's treatment. So although it's a single dose study, we should be able to see impact on biomarkers and clinical phenotypes for up to a month. And other studies are also happening in this space, including industry trials. So Janssen has completed a study of sirukumab, anti-IL-6 monoclonal antibody. Another study happening in UK and US, another Janssen trial targeting, is called ATP trial, so targeting P2X7 pathway, so slightly upstream of cytokines, more to do with inflammasomes. But drugs is not the only way to control inflammation. So dietary and lifestyle interventions could also have an important role in reducing inflammation. And there are also clinical trials ongoing testing effectiveness of those interventions in reducing inflammation and consequently helping depression. I've saved the last thing, the best thing for last. This is evidence from those kind of personalized trials already coming out. So this is a study from a friend and a good colleague from King's College London, Valeria Mondelli. They've recently published a study of myocycline. So it's a tetracyclic antibiotic in patients with depression, but the beauty of this trial is that they selected patients based on CRP levels being high, and they show that there is a noticeable improvement in depressive symptoms in patients who have high CRP levels or evidence of immune activation. So this is an exciting area, a lot of clinical trials happening, so watch this space. So to summarize, depression is associated with evidence of neuroinflammation and elevated concentration of inflammatory markers in blood in at least a quarter of patients. Evidence from longitudinal cohort studies and genetic Mendelian randomization studies strongly suggest that inflammation could be a causal risk factor for depression. Features of inflammation-related depression include somatic symptoms, cardiometabolic disturbance, antidepressant resistance, and so on. Anti-inflammatory drugs do have antidepressant effect, and this is independent of improvement in physical illness. We believe that our field now requires interventional studies to further examine mechanisms, causality, and therapeutic prospect for immunotherapies for patients with depression. The big question for the field is which patients are likely to benefit and what are the characteristics of immunological or immunometabolic depression. But nevertheless, because selection of those patients are likely to be key for success of immunotherapy trials, because in psychiatry, it's about time that we move away from one-size-fits-all approach and think about our patients as person and take a more personalized approach. And immunopsychiatry provides a means for doing that. Finally, I'd like to thank my friends and colleagues, particularly my group here, my funders, and you all for listening. And a little plug before I finish, we have a textbook coming out, Textbook of Immunopsychiatry. It's being published by Cambridge University Press. I'm very excited to share the cover because I got 2 mock-ups from the press yesterday saying, which one would you prefer? And this is the one that won. So it's been a lot of hard work putting this together, and I hope it would be a useful thing for students and colleagues. And I'm happy to take any questions. Thank you.
Thank you, Golam. That was a beautiful presentation and impressive body of work in an area that I think is highly important in psychiatry today. So thank you for that great talk again. So I'm guessing we have a lot of questions. Would anyone like to turn on their camera and ask Dr. Khandaker a question or two? Or provide it in the chat box?
Sure, I have a question about the possible role of naltrexone, regular dose or low dose.
Or are you asking whether a regular dose or low dose would be useful?
Yes, and if there are any trials on that.
There are trials of naltrexone. I'm certainly aware of one being conducted in Australia and one currently under setup in Birmingham, but I'm not entirely sure what the findings for these trials are.
Thank you.
Does anyone else have a question? Jeremy, looks like you may have a question. You could be on mute. I don't know. Are you? No? Okay.
Yuri.
Yeah, hi Golam. It was an amazing overview. You really covered the entire field. It was great. I have a question more than we are moving to the intervention and the translation. So you showed the seminal Miller trial with the stratification based on CRP. So is your opinion that interaction means, of course, first that we need to select the patient to maximize the effect size for the potential anti-inflammatory, so select the best group, but we should protect the other from unneeded anti-inflammatory treatment. So do you think there is going to be also iatrogenic effect for those who have no eye inflammation?
That's a very good point, because Andy Miller made that point last month in his talk, that while there was an indication that patients with high CRP showed better improvement in their depressive symptoms, in fact, patients who had low CRP, their depressive symptoms got worse. So I think that's another very good reason for being careful about designing trials in a way that we select patients that are most likely to benefit. Otherwise, as you say, I totally agree, Yuri, that any drugs, even paracetamol, they come with their own long list of side effects, and we should not be exposing patients to drugs they actually do not need or may not benefit from, or in worst case scenario, actually could be actively harmed from those. And I think that's a very good reason why I believe this is a very important area to work out in terms of which patients would be better candidates or more likely candidates for immunotherapy trials.
So Golam, we have a question from Emmett Power regarding your IL-6, soluble IL-6 hypothesis, which is really interesting. And he asks, can the IL-6 trans pathway be specifically targeted with any available therapeutics? What is your thinking on that?
That's a very good question. I think currently there isn't any licensed product or drug that can be used that targets IL-6 trans signaling specifically, but a lot of work is currently being done. So there are a number of molecules that are under development. One of them has progressed to phase 3 trial. So it's a GP1. So to give you a bit of background, so for IL-6 signaling to happen, so IL-6 needs to bind with IL-6 receptor, and that IL-6 receptor complex then needs to bind with a protein called GP130, so glycoprotein 130. And glycoprotein 130, when it binds with that activates signaling. So there is a compound being developed by a German biochemist, and he is probably one of the leading figures in IL-6 signaling biology, Stefan Rose-John. They have created a compound that blocks SGP130, and that is currently being trialed for inflammatory bowel disease, if I'm not wrong, in Germany. So a number of compounds are being developed.
Yeah, so it could be interesting too I mean, the feasibility of looking at SGP130 as a potential downstream biomarker too, in depressed patients.
Absolutely. I think for following on from the Mendelian randomization studies that we have done, we are looking at particular proteins that are involved in IL-6 signaling along the pathway, including GP130. I totally agree, because these could be interesting targets on their own right.
Yeah.
Thank you very much. Fabulous presentation. Really enjoyed it. I noticed that your ongoing randomized controlled trial, you're also measuring cognition, potentially to see how that might change. I'd love to hear your thoughts about what you're measuring and how you might expect your trial to change cognition.
Thank you. That's I really appreciate the question. With the trial, we thought a lot about our choice of cognitive measures, and this was informed by a number of systematic reviews of cognition in patients with depression, and also effects of inflammation in healthy volunteers. The particular cognitive domains that seems to be influenced by inflammation are sustained attention, reaction time, spatial navigation. And these signals have come out repeatedly in a number of studies. The person that comes to mind being most active in this field has been Neil Harrison in Cardiff University. So we've taken the lead from them. So the battery we are using is called, it's a computerized cognitive task battery called CANTUB. And we are testing sustained attention, reaction time, executive memory, spatial navigation. Our hypothesis, as you could expect, that the inflamed group, with patients with inflammation will, because the previous studies have been challenge studies, so they make people inflamed and show that the people perform worse. And in this trial, we're doing the opposite. We're actually reducing inflammation. So my hypothesis is that this performance in these tasks will get better.
Look forward to seeing the results.
Thank you.
Golam, I have a question too. With regards to depression, clinical depression diagnosis, I was thinking back to your data, which you did an amazing job with summarizing the literature, and then also some of your great studies that have come out recently and critically evaluating it from an epidemiological perspective and a meta-analytical perspective, and looking at these trials. And the argument for a causal effect with inflammation and depression, starting in some of those studies that looked at 9-year-olds up, to 18-year-olds, where does reoccurrence of depression fall into some of these studies in terms of where is inflammation at the first occurrence of depression, and then how does that change over that longitudinal period? Are studies looking at it from that perspective? And what can we learn from that first episode, which in one of your first slides, in terms of incidence of recurrence of depression and how that you get into that cycle that takes over? Like how are studies viewing that when they're recruiting subjects, when you're designing your studies? Could that be an important component to this relationship?
I believe this is a very important point, because in studies in adults, it's very clear that the association between inflammation and depression is in fact bidirectional. So Yuri would know this very well, and they show this evidence very clearly in NESDA cohort, that higher levels of inflammatory markers are associated with depressive symptoms and vice versa. And we know that some of the risk factors for depression, such as smoking, psychological stress, alcohol abuse, and sedentary lifestyle, these are also inflammogenic, so they promote inflammation. And other thing to consider, as you've pointed out, that with recurrent, so there will be cumulative effect of psychological stress, accumulating physical comorbidities. So some of the physical comorbidities, such as cardiovascular disease, type 2 diabetes, which are common in depressed patients, they're also associated with the pro-inflammatory phenotype. So I suppose in working age adults with established illness, it's probably very likely to be a bidirectional feedback loop, one feeding on the other. I think Andy Miller used the analogy of a depression feeding on the flame and then fanning the flame itself. I think that's quite apt, that there is a bidirectional association, that one promotes the other and it becomes a vicious cycle. But to answer your question, whether the studies actually look at association of inflammation with progression and recurrence, those studies are relatively scarce. We have used longitudinal data from ALSPEC, which I haven't shown here today, where we modeled repeat measured depressive symptom data between age 10 and 20. So we use the same questionnaire in the same cohort 6 times between age 10 and 20. And when we modeled the data into trajectories, we found that there were 3 trajectories of people. So 80% of the sample they had very little depressive symptoms at any stage. So by and large, they're happy teenagers. About 13% of the sample had depressive symptoms pretty low up to teenage, but then it took off after puberty. So we call them adolescent onset depression. And about 5 to 7% of the group had persistently high depressive symptoms throughout. So we call them persistent depressive symptoms. Interestingly, what we found that IL-6 and CRP levels in childhood were strongly associated with the persistent group and not it was compared against the healthy group. The risk was higher in the adolescent onset group, but it was explained after adjustment for confounding, but the main effect remained for the persistent group. So my hypothesis for studies with recurrence would be that we would expect persistent inflammation or inflammation to be associated with a more severe course of illness, so progression into recurrence. But really, there isn't a lot of evidence out there, and this is a great question.
Mm. Okay, yeah, thank you. Thank you for that. That's helpful. Does anyone have any other further questions? See, nothing in the chat box. Well, yeah, thank you again, Dr. Khandaker. This was a beautiful talk, and I appreciate you taking some time for questions as well. And I hope that we could see you in person sometime.
It's a pleasure, Paul. Thank you very much for inviting. And it's a good evening from England, and I'm sure it'll be a good day in Washington, D.C.
Yes. All right. Thank you. Take care, Golam.
Take care.
We'll be in touch. All right. Bye-bye.
Bye-bye.
Thank you all for attending.